So welcome everybody to the defense of Azadeh Akhavanalov, who will tell us about her thesis entitled Strategies for Radiation Dose Monitoring and Optimization Diagnostics and Therapeutic Nuclear Medicine Procedures. So the procedure will be as follows, that we will first have a talk by Azadeh, 45 minutes. Afterwards, we will have questions by the jury, which I will introduce shortly. And then afterwards, other people joining us and having a PhD can also ask questions. After that, we will deliberate. The jury will deliberate, and then we will announce the outcome of the thesis defense afterwards. So now I would like to introduce the jury, and I apologize already for many names that I will not pronounce correctly, I'm afraid. And I will do it in alphabetical order because everybody is very far away from me, at least. So let's start with Professor Manuel Bardiez, who joins us from Montpellier, I guess. Then we have Professor Wesley Bolch from the University of Florida. Then Professor Yuni Devaraya from the University of Michigan. And finally, Professor Arman Ramim from the University of British Columbia. And the thesis supervisor was Professor Habib Saidi from the University of Geneva. At least I guess Habib's name I know how to pronounce more or less correctly. And finally, I have the pleasure to be your president today. So my name is Carsten Kruse, here from the Department of Biochemistry and Theoretical Physics at the University of Geneva. And I guess without further ado, I leave the mic to Azadeh. So please go ahead.
Okay. Thank you everybody and welcome to my presentation. I appreciate your time. The topic of my PhD dissertation was about strategies for radiation dose monitoring and optimization in diagnostic and therapeutic nuclear medicine procedures. The outline of the thesis is mainly in two parts. In the first part, we work on diagnostic nuclear medicine dosimetry with the focus in the first phase on mainly computational model and patient-specific computational modeling, and then Monte Carlo simulation code development. And in the second phase, we mainly work on the implementation of deep learning algorithms in nuclear medicine dosimetry. And in the second part, we did some work on therapeutic nuclear medicine dosimetry with a focus on radiopharmaceutical therapy. Let's start with a background on radiation dosimetry. There is a vast spectrum of electromagnetic waves from a low energy to high energy that the focus of this work was mainly on ionizing radiation. As you see in the pie chart, the public exposure from ionizing radiation is about 50% from medical imaging. And in this pie chart, the highest contribution of the dose to the public exposure comes from computed tomography, following by the nuclear medicine. As you see, I provided one example from a whole body FDG, a hybrid modality of nuclear medicine PET-CT that deliver about 18 millisievert dose to the patients. There is some evidence indicating that there are some association between low dose radiation exposure and a potential carcinogenic risk. That's why ALARA principle, as low as reasonably achievable principle, has been defined in radiation safety. So we face kind of risk-benefit optimization that for a quantification of the risk, dose quantity has been defined. In diagnostic procedures, we mainly want to minimize the dose to achieve acceptable diagnostic quality, while in therapeutic nuclear medicine, we mainly maximize the tumor dose while we want to minimize the dose to healthy tissues. We know that the absorbed dose within human body cannot be measured directly, so it must be assessed from simulation results. There are three main components for the simulation development of the simulation study. The first is the radiation source definition, could be external X-ray source or biodistribution of the administered radiopharmaceutical. The second parameter is the medium of radiation interaction, that here is patient anatomy in the dosimetry. And the third part is the radiation transport algorithm. We know that the gold standard in dosimetry simulation is patient-specific Monte Carlo simulation. The Monte Carlo simulation is a numerical solution to the Boltzmann radiation transport equation. That this numerical model directly simulate the fundamental interaction of particle with materials. Monte Carlo simulation has the main advantage that is modeling complex problems with a very intricate geometry that we want. However, there is a disadvantage for Monte Carlo simulation that it's about high computational burden and long execution time and the expertise that is needed for computer programming. There are several applications for Monte Carlo models in medical physics, from detector modeling, system design, image reconstruction to patient dosimetry. About the surrogate of patient-specific anatomy in those simulation, there is a history over 15 years old for that started with a very simple ICRU spheres, then upgraded to the physical phantom, that simple objects represented the organ of the human anatomy. Then by the advent of computed tomography, the 3D voxel models has been developed that were more realistic for representation of the anatomy. Then boundary representation model, surface-based and mesh-based model that was more flexible for deformation and moving was developed. And the ultimate goal for computational phantoms is patient-specific computational model. We are talking here about 2016-17, before the revolution of deep learning in at least medical image segmentation. So some reference, therefore the problem for patient-specific computational phantom was manual segmentation of the medical images, let's say CT here. It was labor-intensive and time-consuming for construction of patient-specific computational models from medical images. Therefore, reference computational phantom has been defined. The reference computational phantom was the computational model that was developed based on a average anthropomorphic parameters in a general public. We have different model of this reference computational phantom, ICRP reference model, even pregnant model and fetus model. And also there are some reference computational phantom family that they are separated in age, gender, that they are from NCR reference phantom family. So we introduced the components of the dose simulation. So here we want to move on the existing dose reports in clinical setting. For computed tomography, the dose metric is the CT dose index or dose length products. That these metrics indicate the radiation output of a specific scanner on the specific acquisition protocol, while we need kind of estimation from organ level dosimetry for risk estimation. So the potential solution that there exists currently some commercial software packages for organ level dosimetry from computed tomography was that Monte Carlo simulation using reference computational phantom under a specific exposure scenario. This commercial software like Radiometric, Impact CT, and NCI CT contains some lookup tables of organ dose values that are pre-calculated in Monte Carlo dosimetry and using the reference computational model under a scanner, a specific model, and different acquisition parameters. In the case of nuclear medicine dosimetry, administered activity is something that is reported in the clinical setting. So for organ level dosimetry, we need kind of risk estimation. Thanks to MERT formula and thanks to Professor Bolch that he's presented here. This is a really old but still very practical formalism that in MERT schema, the body is considered as the combination of source organs and target organs. That source organs are those with significant uptake of radiopharmaceutical, and target organs are those that are irradiated by source organs. So using the MERT formalism to provide an estimation of organ level dose, we have a multiplication of accumulated activity by the S value. S value is defined as the mean absorbed dose to the target organ per unit activity in the source organs, multiplied by the accumulated activity in the source organs, that this accumulated activity could be obtained from standard biokinetic models or from a patient biokinetic measurement. These S values are calculated using Monte Carlo simulation that has been predefined based on their reference computational phantom. There is some software package that OLIDA is one of the oldest package that still is useful in clinical setting, and these softwares and commercial packages contain, based on the MIRDA schema, contain kind of lookup table for organ S values based on different radiopharmaceuticals. Okay, according to the background that I presented, here we want to focus on the first phase of our study, patient-specific computational model, Monte Carlo dose simulation, with a focus on hybrid PET-CT examinations. In the first study, we mainly focus on the development of a computational phantom library. We know that the reference computational phantoms have been developed in different age and genders, but based on average population anthropomorphic characteristics. Therefore, to cope with intersubject variability of anatomical characteristics, we developed a habitus-dependent library of computational phantom composed of over 479 male and female adult phantom in 7 age groups and 49 height and weight grids, that in addition to anthropomorphic parameters, we consider the correlation of organ masses with respect to morphometric parameters and waist circumference and body mass index. And this computational phantom was extended from ICRP adult reference phantoms. In the second work, we developed a methodology for construction of a patient-specific computational model from regional CT images. And in the second step, we further implemented the patient-specific computational model that we developed from this methodology into Monte Carlo simulation organ-level dosimetry to compute the dosimetry from the corresponding CT exposure. For construction of a patient-specific computational model, we conducted 3 main steps. In the first step, we obtained the regional CT images segmented by thresholding of Hounsfield unit to line, bone, and body contour. In the second step, the best fitting model from our previously developed computational phantom library was selected based on gender, age, height and weight, called here anchor phantom. And in the third step, the anchor phantom was deformably registered to the 3 class of mask that we obtained from the first step here, from regional CT image, and called here patient-specific phantom. Here there are some representation of the original CT that was segmented through manual segmentation, the best fitted from computational phantom, anchor phantom, and the patient-specific phantom. In terms of organ level dosimetry, we compare radiometric anchor phantom and patient-specific methodology compared to the ground truth. You see that patient-specific outperform compared to the radiometric software package that is based on the reference stylized computational phantom and also anchor phantom model. And specifically, if you look at the lung dose, the precision in the lung dosimetry is better because lung was the organ that was segmented based on the regional CT of the patient. In the third study of this part, we developed and validated a Monte Carlo CT simulation code using some physical phantom measurement, and then we further assessed the impact of scan-related parameters on dosimetric calculation. Again, 3 main components of the simulation code was introduced to our simulation. The source tube geometry was obtained from Siemens manufacturer, the detailed geometry. The computational model of the physical phantom that we measured was constructed through the registration-based model that we developed for patient-specific computational modeling. And the acquisition parameters that introduced to the simulator was obtained from 2 sources of information. The first one was from raw data that is not something available, and it's a complementary set of information. It's not available to the clinic. And the second one is a DICOM header of the CT images that is available for the clinic. Here we compared the different methods in organ level dosimetry. Mean absolute error organ absorbed doses from experimental measurement against from exact simulation with the information from raw data was about 14%, while it was about 29% from image-based simulation. And we can conclude that when the information for the CT raw data is not available in CT dosimetry, the image-based simulation result could be acceptable if we model the longitudinal tube current simulation in the dosimetry workflow. If the simulation points in Z direction is less than 6 millimeter interval, and by random selection of tube start angle and ignoring overranging of the start and stop part of the region scan, some uncertainties might affect the small organ doses. To sum up the three study that we conducted in the first phase, Monte Carlo dose simulator was developed for both external and internal exposure. Toward patient-specific dosimetry, we constructed a habitus-dependent library of computational phantom. We developed a registration-based patient-specific phantom construction methodology. And now we are taking, after revolution of deep learning in fully automatic segmentation of medical images. So these days, patient-specific computational phantom construction from structural images, let's say CT or MRI, is something feasible thanks to deep learning algorithms. The current limitation of deep learning for construction of patient-specific phantom is the segmentation of tiny structures. The micrometer thick radio-sensitive layers of elementary respiratory tracts, detailed eye model, bone structure, and the potential solution in this regard would be using deep learning for organ segmentation as much as organ that we can, and then go through a contour-guided deformable registration of a detailed reference computational phantom to a original patient CT, and using the mask that we provided in the first step. The second phase of this part is implementation of deep learning algorithm in dose optimization and monitoring. The first study here, we design a low-dose CT protocol using deep learning for COVID-19 patients. In the first step, for simulation of the low-dose CT, we use the full-dose images, and by scaling the incidence flux in the cyanogram domain and adding some Poisson and Gaussian noise and reconstruct the image again, we constructed a low-dose CT simulation. We applied a residual neural network to predict full-dose images from low-dose CT images. About 1,100 chest CT from 9 medical centers was implemented for this study. Here, the quantitative comparison between recovered images with respect to the ground truth shows an improvement compared to the low-dose images. In terms of qualitative comparison, you see that quality scoring shows that the recovered images are scored as 0.4 point, full dose 4.7, while the low dose was scored as 2.8. Here, I provided two examples of full dose, low dose, and the predicted and recovered low dose CT images. For the first case, you can see that deep learning improved image quality and diagnosis at the same time, while in the second case, deep learning improved image quality but changed the diagnosis. In the next step, we implemented deep learning method in voxel-based dose calculation to provide some dose map with comparable accuracy to Monte Carlo while reasonable time. So we made a novel problem formulation for Monte Carlo dosimetry. We made an image-to-image translation problem to solve through a deep learning algorithm. We implemented this method for both internal and external dosimetry. In the first study of this part, we implement deep learning algorithm into real-time Monte Carlo dosimetry from CT examination. We know that in the helical CT examination, the dosimetry is based on combination of a multiple source position in a helical route. So we designed and trained our model in a single source mode. the same as the real dosimetry workflow. Here you see the graphical workflow that our network is inputted with two channels. The first channel is the density map, and the second channel is the SP uniform here, single point Monte Carlo dose in uniform material. This SP uniform channel provides the information of source position and the angle that we have, and the output is the dose map for a single source exposure from Monte Carlo simulation code that we previously validated, developed and validated. In this work, over 28,000 source positions were included, and we further tested generalizability of the model versus tube voltage. Model performance was based on 120 and 90 kVp spectrum that has been evaluated in this model. Here I provided one example between deep learning versus Monte Carlo dose map in voxel level dosimetry. We compared these to method for both tube voltage that you see in a quantitative metric comparison. Relative absolute error was about 7% for 120 kVp, and for 90 kVp it was about 8.6%. The joint histogram shows the correlation between deep learning voxel-wise dose map against Monte Carlo ground truth with a coefficient of determination over about 99%. Also, we compared organ level dosimetry that you see in both tube voltage. We could calculate a mean relative absolute error of about 2.5%. So to conclude about this work, a deep learning model can generate whole body dose map from CT images with an excellent performance on organ level dosimetry. The continuation of this work is just increasing the number of training set, and we are trying to improve the performance of model in different density tissues. And the current step is developing a fast Monte Carlo dosimetry framework to develop a deep learning model for denoising the low precision dose distribution that is constructed from a few simulated particles to predict a high precision dose distribution that is constructed from a large particle simulation stories. In another study, we implemented the fast Monte Carlo-based dosimetry using deep learning in internal dosimetry. The core idea here is inspired from the mirrored voxel scale dosimetry formalist, where a single voxel S value in a homogeneous soft tissue medium is convolved with the activity map to produce a whole body dose map. The limitation of this single S value model is that it ignores the heterogeneity of the interaction medium. That's why in 2018, Lee et al. Proposed multiple S-value models. They considered medium heterogeneity by providing a multiple tissue-specific voxel S-value. However, they mentioned that using 4 different density maps, lung, soft tissue, and 2 classes of bone density, they provided very better dosimetry compared to reference Monte Carlo. However, still the specific kernel here are homogeneous. So the MSV or multiple S value relies on the basic assumption that energy deposition in each voxel means raised from the self-absorption. Therefore, we proposed a novel methodology to concern voxel-wise medium heterogeneity based on the patient-specific density map for internal dosimetry. Here you see the graphical workflow that we have splitted in 2 steps. In the first step, we train a neural network to predict specific kernels according to the patient voxel density map. The input here, as you see, is the density map sample from a patient CT images, while the output is the dose kernel from Monte Carlo simulation, where the unit activity of the given radio tracer are localized in the central voxel of the density map. We use here from Monte Carlo simulation code that we previously developed. And in the second step, analogous to the mirrored formalist, we constructed the whole body dose map by convolving the specific kernels to patient activity map. The difference with our methodology and Mirrored formalism is that we had specific kernels based on patient anatomy. However, in SSV and MSV, we have homogeneous kernel. In this work, the resonant architecture was employed and 12,000 density maps were sampled for the training and testing the model using FDG radio tracer. If you can see the specific kernels are compared between deep learning versus the Monte Carlo simulation, that the line profile show a good agreement between them. And also voxel-wise, we compared in a joint histogram that we see that a coefficient of determination about 98% has been calculated here. For those distribution analysis, I would like to show the impact of medium heterogeneity on the dosimetry by providing the posited energy map from a computational phantom that is filled with the activity distribution. From the top images, you can see that a single S value overestimate or underestimate the dose depending on the voxel density map compared to the soft tissue density. In the lung tissue, it's obvious from the line profile, and from the multiple S value. However, MSV can correct the SSV ignores in large volumes with heterogeneous density. Still, there are some errors from MSV in the small heterogeneous regions based on the basic assumption of MSV that it's assume the main contribution of the dose in a voxel comes from the self-absorption. In the bottom figure, we compared voxel-wise different methodology based on the patient-specific dynamic scan that we had. Deep learning provide a 2.6% of mean relative absolute error compared to Monte Carlo. Here, the organ level dosimetry has been compared between different methods. We can conclude that large level in organ level dosimetry, deep learning and MSV provide comparable results with Monte Carlo. However, SSV accuracy depends on the density of the organ of interest compared to soft tissue. To sum up about this study, we can conclude that deep learning method outperform conventional voxel level and organ level mirrored-based formalism. And also, the proposed methodology is very easy to be extended to other radiopharmaceuticals. That we extended the proposed methodology in this work to lutetium dotatate, and the data is under preparation. Just to briefly discuss about the implementation of an extension of the methodology that we propose for internal dosimetry to brachytherapy dosimetry. We implemented a deep neural network for fast Monte Carlo voxel dosimetry in brachytherapy to address the simplification of TG43 formalism, that is the main formalism for brachytherapy dosimetry, that the voxel dosimetry is calculated in a volume, water-filled volume. We developed this deep learning-based methodology to correct the impact of patient heterogeneity into the dose maps. Specifically, we have this problem when we have metallic catheters that really TG43 can't model the impact of this inhomogeneity. In the first step of this work, we developed an automatic pipeline for Monte Carlo-based personalized brachytherapy in a single dual dose map. Then, using the treatment plan, we provided a combined dose plan by superimposition of the single dual dose map. And in the second step, we implemented a residual neural network that was inputted with 2 input channels. The first one was a patient-specific density map, and the second one, input was a dose map in a water-filled media that introduced the information of source position and orientation. Here you see the comparison in a single dwell and a combined dose voxel scale quantitative comparison from line profile and joint histogram. We can see a good agreement between these two methods. And also from quantitative metrics, we compared the dose volume histogram metrics from clinical dose metrics that you see deep learning with respect to Monte Carlo outperform TG43 formally compared to Monte Carlo in the quantitative metrics of clinical parameters. If we want to conclude about all the study that we implemented the deep learning in nuclear medicine dosimetry, we can see that deep learning was implemented for CT image recovery and denoising from low-dose CT images. Deep learning algorithm showed promising results in dose construction from multiple modalities, enabling real-time Monte Carlo-based dosimetry. In diagnostic personalized nuclear medicine dosimetry, we mentioned that we need kind of organ level dosimetry. So deep learning, the potential solution is deep learning based voxel dosimetry followed by a deep learning based auto segmentation. However, there are some potential challenges for voxel dosimetry using deep learning. In computed tomography, we know that there are some acquisition parameters that they are not linear with the output Monte Carlo dosimetry, like tube voltage that we studied in our work, the collimation weights, and the geometry of the source scanner. So the potential solution would be to model this acquisition parameter in multiple models and use the transfer learning, something that we showed for, with respect to tube voltage in our study. And the second potential challenge in internal dosimetry is the patient-specific time-integrated activity that we need. Actually, we need, because in diagnostic images, we mainly have a static images, while for biokinetic modeling and time-integrated activity of a patient, we need kind of dynamic scan information. The potential solution is something that is a hot topic in radiopharmaceutical therapy, single time point dosimetry. I think Uni and Arman are expert here for this single time point dosimetry. So the potential solution is something that we can make a data-driven model from available dynamic scan to provide some information and some estimation of time-integrated activity based on the diagnostic static scan. The last part of our study is therapeutic nuclear medicine dosimetry. In the recent years, we know that the emergence of diagnostic led to the resurgence of radiopharmaceutical therapy in this domain. Diagnostic in nuclear medicine mainly refers to the pairing of imaging and therapeutic agent that share a specific target. There are multiple diagnostic pairs in the clinic, like gallium lutetium, technetium yttrium, that enable clinician to treat what they see. It means that when we have diagnostic pairs using the imaging agent, we can have some estimation prior to the therapy of the biokinetic patient, specifically patient-specific biokinetic and pharmacokinetic modeling that help for improving the patient selection, even adaptation and personalization of the treatment. And also further, we can image the therapeutic agent through this diagnostic imaging that enable clinician to see what they treat for verification of the therapy, adaptation of the treatment in the continuation of the therapy, that all of these benefits are in line with the ultimate goal of precision medicine, that is personalized treatment of the patient. Here I provided a workflow of the radiopharmaceutical therapy. Here the example is gallium lutetium diagnostic pairs. However, some parts are still not implemented in the clinic. We have pre-therapy imaging. Here I provided the gallium dotatate imaging that provide an estimation of the biokinetic of the patient. Then clinician qualitatively evaluate this pre-treatment to check the patient eligibility, and then the therapy still is administered in a standard regimen. Then we have a workflow for post-therapy imaging and dosimetry, diagnostic dosimetry. For diagnostic dosimetry, we need multiple time point of post-therapy imaging of the therapeutic agent in order to make a biokinetic of the patient models, and then we have to construct the time activity curve and calculate time integrated activity of the patient, and then using a dose engine simulator that can be Monte Carlo, that is the ground truth. However, in the case of radiopharmaceutical therapy, we have mainly short range particles. We can use some model-based dosimetry engine like mirrored formalism, or even in some cases using a local energy deposition model. We can construct a dose map and then further check the organ at risk dose and tumor dose for verification of the therapy and adaptation for the continuation of the treatment. And here is the last study that I work on that in collaboration with the University of Michigan. As you see, we predict the lutetium dotatate delivered dose to tumors using pre-therapeutic gallium PET information and clinical pathological biomarkers that was available for this patient. 19 tumors from baseline CT images was delineated by radiologists and transferred to pre-therapy PET images and post-therapy aspect images, lutetium aspect images. In the workflow of the pre-therapy images, we extracted the quantitative metrics from gallium PET images, and also we had available biomarkers data. And from post-therapy dosimetry pipeline that was developed in University of Michigan, a Monte Carlo-based multiple time point dosimetry pipeline, we provided tumor dose quantitative values and made some model to predict this tumor dose from the pre-therapy information. Here I provided the Spearman correlation of pre-therapy information versus the dose parameters. I here presented the decomposition of the dose parameters that is composed of uptake and effective half-life. Here you see the we can see that the SUV parameter from pre-therapy images has a significant correlation with the lutetium uptake here, and the effective half-life has a negative correlation with prior systemic treatment of the patient. Here we compared the SUV parameters with respect to the tumor dose. As in the literature has been reported, if we provide some SUV TNRs, it means SUV normalized by physiological uptake, that for the case of lutetium dotatate is spleen or liver or blood pool. Maybe we can cope with intersubject variability of the tumor SUVs. But here we compared all the SUV parameters that was available from SUV peak, SUV TNRs, and SUV mean. And SUV mean provide the best correlation, higher correlation with respect to the dose. And in the second panel, I provided an visualization of intra-patient and inter-patient variability in the tumor dose, that the color of these spheres are PET SUV, based on the PET SUV, and the size of a sphere shows the tumor volumes. We investigated a cross combination of a different machine learning algorithm to predict tumor dose using available pre-therapy information. The model performance was done on a nested tenfold cross-validation. The best prediction performance was achieved from a trivariate ensemble theory model using only gallium PET SUV metrics, SUV mean, liver SUV, and total lesion of SUV mean, with the coefficient of determination about 64%. If we want to conclude about this work, there is a moderate but significant correlation between gallium PET SUV mean and lutetium uptake in tumors that led to a correlation to tumor delivered dose. This finding is completely in line with the evidences that has been recently in January 2023, I think, 2 other papers has been published with the same result almost. In general speaking, according to the clinical evidence, dosimetry-guided radiopharmaceutical therapy allows for safely optimized tumor irradiation. We can imagine that if we have prediction of the dose, we can improve the patient selection and personalization of the radiopharmaceutical therapy in a way that we have some estimation of the organ at risk dose, so we can keep it under the toxicity dose threshold, or even we have some escalation process that we can check at least if it does touch the toxicity dose threshold. And when we have some pre-evaluation of tumor doses based on the literature, if there is some dose threshold for responders, we can check which patient benefited more from the this specific therapy based on the prior information that we have from the patients. Okay, to provide an overall overview about my PhD dissertation, in terms of diagnostic nuclear medicine dosimetry, we can say that patient-specific computational model is feasible through deep learning segmentation. Fast personalized voxel dosimetry in diagnostic CT and nuclear medicine is possible through physics-informed deep learning models. Image protocol dose optimization is something really feasible using low dose acquisition and deep learning resolution recovery and denoising strategies that I think currently is going to be implemented in the clinic, and still AI challenges for validation in clinical setting. In the case of therapeutic nuclear medicine dosimetry, we know that thanks to diagnostic dosimetry, we can think of personalized dose planning. The challenges in diagnostic dosimetry are still something that we have problem that have to be addressed, the image quantification, motion attenuation, and registration. However, these parameters are all addressed, but really need further investigation. The patient-specific biokinetic modeling, differences in pharmacokinetic and biodistribution of diagnostic pairs that we have. Also, we have some evidence while challenges for personalization of the treatment. There is a really minimal evidence on patient eligibility for radiopharmaceutical therapy using the advantage of diagnostic pairs. We can do some outcome prediction, patient selection, and hopefully improving treatment efficacy.
And now we go.
I can hear from the next room.
Good. Too far away from me, but that's good. So now we start with the questions, and I would like to invite Professor Devaraja to start, maybe.
Thank you, Azadeh. That was excellent presentation. And I see that you have done a lot of work. This is pretty impressive, 9 papers. I'm glad that my students are listening, so they can take a hint. I'm going to start with maybe your work on the voxel, the method would be needed for a pure beta emitter or a beta emitter that has relatively low energy.
Yeah, actually for Monte Carlo dosimetry, as I think we discussed with Habib and colleagues always, that Monte Carlo dosimetry is mainly, I think, the most important part is for some longer range particles, right? You know, because when we have longer range particle, this homogeneity affect more than something that we have lower range particles. We implemented in lutetium this work, but to be honest, when we compare the Monte Carlo dosimetry versus even single S-value mirrored formalist, we can find a good result in the homogeneous soft tissue because it models really low range of beta particles in that way, based on the imaging device and the resolution that we have. We have available some imaging resolution that we know the voxel size is like, let's say, 5 millimeter, for example, and we want to do the dosimetry based on the heterogeneity in this area. So we concluded for lutetium, if we want to implement the same approach to lutetium, we concluded that really S-value, single S-value with correction in the density works perfect in soft works acceptable in soft tissue. However, as we mentioned, we have really problem for bone marrow dosimetry and something like this, because even using multiple S values, I think I showed here, yeah, if you can see my mouse, I think even using multiple S value, we in a small heterogeneous medium, we can't model this heterogeneity for those deposited energy. That's why we think that for small regions with heterogeneity, like bone region here, we need this kind of Monte Carlo. We can't use this even MSV and SSV metrics. That's why deep learning can answer maybe this part as a fast way in comparable accuracy with Monte Carlo.
So you think that even for lutetium, where the beta energy is very low energy and it's very locally deposited, that your method the deep learning method would have an advantage over the MSV?
As I mentioned, we implemented and we saw the differences. Yeah, the differences. Yeah, the data is under preparation for the publication. My colleague Zahra is working on that, and we saw these differences even for lutetium. But to be honest, it's something that I do believe to MSV for model-based is fine.
Okay. Also, for this work, you mentioned that you used a residual network. Could you explain what was the reason for the residual? What were the inputs for the residual network? Yeah,
here we used a single channel residual network. We introduced the density map of the model of the sample from the CT images, then converted to the density map. And the main objective was to construct a model could find the heterogeneity of the density and map on the dose map. And the residual network, to be honest, we tried multiple model unit residual networks for this regression model, but there is a paper, I think, also that they mentioned residual network for regression models in deep learning regression model outperform, but that's why for most of our regression model we use residual networks. However, these days I think my colleague used another network, residual unit, ResU network, but it's worthy to note that we extend this work to lutetium with a simple difference. We included two input channels to the network. First was from single SUV to have the same magnitude of the dose with the output from Monte Carlo, and just ask residual network to correct for heterogeneity in the density map. And it outperformed. You know, when we compare two networks with single input and two input, the performance of the model improved.
I see. So you think there's any benefit in doing a quick Monte Carlo and looking at that as in the residual network, doing with very few histories? Do you expect to see any reason to do that?
For fast Monte Carlo, you mean?
Yeah, do a fast Monte Carlo.
Yeah, fast Monte Carlo. Yeah, fast Monte Carlo. I think it's mainly better for CT dosimetry, because, you know, in CT dosimetry, a bit is different from the internal dosimetry, because when we have external exposure, we want just to let's show you here. We want to have some like estimation of the dose distribution in the area based on something that we provided the simulation results based on a uniform phantom to the network. For deep learning, I do believe fast Monte Carlo make better the results. However, I think it's really fine for organ dosimetry. The accuracy of this model was really fine. My colleague Yazdan did this work very perfect. And for fast Monte Carlo, for sure the result would be better, but about the timing that is added, you know, for simulation of the fasting, it might take like 15 minutes at least, I think. However, without using cluster, just simple 10 core, the things that we used in the research, I'm sure that it increased in CT dosimetry. For internal dosimetry, I think it's not needed even.
Okay, so one other question I have is, you have done a lot of different, so there's a lot of different chapters. One thing I find a little bit missing is maybe some connection between the chapters. So for example, you have a nice deep learning code that you developed for deep learning based works S-value methodology. I was expecting that to be used in maybe the next chapter when you talked about the brachytherapy application. But you're also telling me that some of that other work is in progress, the application of that, of some of the things that you developed. Was there a reason that that approach could not be used in what you presented next for the brachytherapy application?
Yeah, exactly. You know, we mainly the method that developed in this work. You're right. We plan to include the lutetium dosimetry as well, but then we decided maybe for positron is fine. But you know, for brachytherapy, we just developed the same formalism, because in internal dosimetry, it's here. In internal dosimetry, we know that we have multiple kernels that we produced, and in brachytherapy is exactly the same. We have some, you know, the main point of brachytherapy is that there are multiple dual positions that seeds stay there based on the planning that they provide, and it's exactly kind of internal dosimetry. And for the simplification, they do TG43 formalism, that is a kind of homogeneous water-filled phantom. Exactly, it's something analogous to the single S-value mirrored formalism. So we mainly extend the idea to the brachytherapy. It was not something that we use the same things, because for Monte Carlo simulation, we completely implemented a new platform, completely automatic. It's something that we just have to address the CT, and the whole work is automatic, and the whole work is different. Just the idea is the extension of the internal dosimetry.
Yeah, so maybe something to think about tying the chapters together a little bit more. I guess do I have time for one last question?
Sure.
Maybe, yeah, this is something, again, something that you haven't got into is the radiobiology. How important do you feel that considering radiobiological factors would be for example, the work you're doing with the lutetium dotatate? Is it something that you should discuss a little in your thesis? I know it's not, you certainly don't need to write another paper, but in the case of lutetium dotatate, we don't think it will be all that important because of the low dose rates. But if you're looking at dose response, maybe something to think about in the future.
Yeah, for sure. We have lots of plans for the future.
Yeah.
Hopefully, yeah, you're right. But I don't know if you think that we have to include some part in the conclusion.
Maybe conclusion that that was not looked at in this work.
Okay.
Okay, thank you.
Thank you so much.
Great job.
Okay, thank you. And then I suggest that we continue according to the list that I have here. So Professor Bolch would be the next one.
Okay, very good. Azadi, it's so good to meet you, and I've read and followed your work, and it's nice to meet you in person, at least virtually. So
thank you. I met you before, Professor Bolch, in a conference.
At AEPM or SNM?
No, it was a computational phantom in Munich.
Oh yes. We haven't met that group in a couple of years now.
Yeah.
Let's think. So a couple of questions. So the patient-specific phantom library that you've developed, is that that's the final versions are still in voxel format, or have you moved into polygon mesh format?
No, not really. We put in because you know the main purpose for this work was to be kind of automatic workflow. So we started with voxel and put it in the voxel to introduce to Monte Carlo easily.
Yes, very good. Second question on the CT modeling, you had mentioned tube current modulation. I think you addressed this when I wrote down my question. So the obviously, if you're going back and doing a dose reconstruction, you can pull the MA modulation from each of the axial or reconstructed slices. For prospective, right? You have your patient matched phantom, and you haven't done the CT yet, but you want to predict what the CT is. So tell me a little bit about your how your system works on predicting dose under tube current modulation before you have actually irradiated the patient.
Nice question. Yeah, it's something when we want. Actually, it's something that my colleague Yazdan is actively working on. That it's a research question that we are working in our group. It's something because we know that tube current modulation, even in commercial manufacturer, is based on the attenuation that they have in each view, in each angle that the source is from the patient. If we imagine that we have this patient volume model, that Yazdan did some work in this area. If we imagine that we have the voxel model and the density map of this patient, and we want to modulate the dose, we just want to have some estimation of this formula. We have Beer-Lambert for attenuation, I0 E minus mu t. So we have this mu, so we can use some estimation of this I0. And our plan is something that we have the output of all angles almost in the same magnitude. That's why we can modulate. If we have like one I prime, that is the output of the detector reading. If we want, we know that this threshold, this I prime is that, we can use modulation based on this formula. This formula, right?
So yeah, you're using so you're using the anatomy of the phantom at that position of the X-ray tube to infer what the modulation should be in a kind of a generic fashion.
Yeah.
Yeah, very good, very good. Well, that's what we're doing. So that's exactly right. And of course, that could be modified at some point if you had more vendor-specific information about what their algorithms were. On the very good work on essentially predicting full dose CTs from low dose CTs using your deep learning algorithms, you had mentioned in past that there were some changes in the diagnosis based on the simulated images. Could you elaborate what those are a little bit?
Yeah, because in this work, we mainly focus on the qualitative comparison of these patients. We know that in a COVID patient, we have some different diagnoses. The name is a bit difficult for me.
Yeah.
But GGO was something that showed. We had 4 class of diagnoses, I think, that one of them was more patchy and the other one was more consolidated. And we know that, unfortunately, there are some effect of over-smoothing from deep learning, that this over-smoothing caused shifting from this GGO to consolidation for some cases. We had these things because we have 2 problems in this work, the 2 limitation really. The first limitation was the data that we simulated was very low dose. We had some kind of strike effect even. However, we checked all of the, patient specifically, we checked the noise level in the upper part of the liver and also some homogeneous part of the lung. But, it was still simulation. However, we compared with real low dose data. But the data that we simulated has some strike noise and some different noisy pattern than real low dose. And the other problem was over-smoothing of the CT. That is an active area, I think, in deep learning, that people are working on this over-smoothing for denoising and recovering of CT images.
Yeah. So presumably, if your input was not ultra low dose CT, but maybe a moderate low dose CT, your success in recreating the higher dose or higher MA generated CT would be better.
Yeah, sure. At least
Just
better
a-
than this.
Yeah, just a thought for future research. Another application is stroke patients. Stroke patients go through 4 different CT protocols. They're all relatively high dose. That would be a wonderful application for deep learning simulations. If we could lower the MA on some of those protocols for stroke patients, that would save a lot of dose to thyroid, cranial bone marrow, things like that. So very good.
Yeah, thank you.
So back just on that last question. So were the artifacts that would change diagnosis in a real patient, was it minor in terms of how the patient would be treated, or yeah, based on this error, would a completely different COVID treatment be prescribed? You see what I'm saying? I'm trying to get the clinical what was the clinical impact of the image artifact that led to a different diagnosis?
I think
Does that make sense?
Yeah, I think for COVID patients, because it was really something. I think this paper was one of the papers that was really submitted very early, when we have a few number of 1,100 CT images from another problem that we had. It was from 9 medical center with different CT acquisition system, and the protocol was the same, but the system itself was different, with different technological things. But the main thing for this was for COVID patient, for COVID patient, I think mainly it was positive, negative, something like this. The type of I know that the consolidation is something that means severe. It will go to the nodular node or something like this later, and more difficult to be treated. But about the clinical impact or the medication that they provided, to be honest, I can't tell you something.
Yeah, okay. I was just curious. Yeah, thank you. And then I think my last technical question, Uni had mentioned, is in your opinion, is the research and efforts in deep learning applications well spent compared to just moving to GPU-based Monte Carlo and just running it faster?
It was
right?
something.
I mean, yeah.
Yeah, it was something that I wrote in the conclusion, and I removed it.
No. Well, I mean, it's an exciting field. Everybody obviously is seeing different applications. It's just kind of what is the landscape? Is this moving forward clinically? Will be putting dose estimates and dose records into patients based on deep learning or faster Monte Carlo, I guess. Yeah, because you would never say the deep learning is the ground truth, right? You always tend to defer to the Monte Carlo. So
yeah, I agree, because
go ahead.
No, go ahead.
No, that was my question.
Yeah, I do believe that for therapeutic purposes, for sure, for external beam therapy and something like this, I think the gold standard would be something GPU based, using quantum generation of the computers. It would be more, tangible to work on that. But in terms of diagnostic, we just need kind of simple estimation of that. So, and we see that deep learning show really promising results for CT dosimetry, for internal dosimetry. I think it's worth to work at least on diagnostic part, because, for example, for internal dosimetry, we have long range data, long range particles like photon in positron emission tomography and something like this. It's very simple for deep learning to make a model and provide some output based on the physics of a problem that we provide. I think for diagnostic, at least when we haven't yet something established, it would be the solution. At least for CT dosimetry, we see, even we have in Geneva University, we use a ready metric software package for organ dosimetry. And we had lots of differences compared to our Monte Carlo ground truths. And you see that this deep learning really had a good performance. At least in voxel level, it was 7%. And in organ level, it was 2.5%. I think it's really something that we can think for the current situation that we have.
Right. I think that's a great answer. I mean, yeah, it could clearly help diagnostic dosimetry, including CT, and it could be explored in therapy, but always acknowledging that Monte Carlo would be the ground truth. So thank you. And my last question is, what is your next step? What do you do next?
Yeah, for the moment, actually, I plan to continue in University of Michigan under supervision, Unidevarojo, and also collaboration with my supervisor, Dr. Zaidi.
Okay.
And I have a fund from Swiss National Foundation for a 2-year postdoc to continue,
fantastic.
my research here. And for the moment, with uni, we have like 3 started research question that we are working actively on that, and hopefully we can work mainly in the clinical part in prediction of the response and something like this.
Wonderful. Thank you very much. Appreciate it.
Thank you so much.
Thank you. And the next on my list would be Professor Badiez.
Thank you very much. It's always difficult to ask questions at the end because you fear that all the relevant questions have been asked before. I'd like to start thanking you for the invitation, and you and obviously Habib for inviting me to this jury that gave me the opportunity to see your work. And I must say that I've been impressed. As Eunice said, 9 papers. I've never seen that in a PhD before. Just that, and then your presentation was very clear, because and that was challenging because you've been working in different domains. You have not been, even though one can see a trend, sort of constant, but there's also been evolution and applied in different fields, which obviously makes things more complicated because it's not so easy to be competent in different fields, especially when you are at a stage of a PhD project. Well, it's always difficult after, right? But you hide it better. So when you're a PhD student, it's very difficult to hide when you have some flaws. I will not ask you questions about, very technical questions. I'd like to reverse the order, like in a paper, you do general comments and then specific comments. So I'm going to start with specific comments. In the document and also in the presentation, I tend to be very, very fussy in using absorbed dose instead of dose. And that is because I've been always working in nuclear medicine. And in external beam radiotherapy or in radiology, there is no ambiguity possible. But in nuclear medicine, there's a huge ambiguity with people like radiopharmacists using dose for activity and also for milligrams of something. So that's why I used, absorb dose all the time. There are little things like that. I've got a question, and you're not the first one, right? So it seems to be this general ambiguity with the use of the word formalism. And I'm quite glad that Wes let me give that comment. You've been mentioning several times the word formalism, and you say, that result is not the same as the word formalism, etc. In fact, you're always using the word formalism, right? Then what you have aside of that is MERD produced S values or MERD produced voxel S values, but you could have, different production of S values or voxel S values, and you actually have a lot in whenever you're doing convolution, and but it's still the MERD formalism, So I think it's important to mention this.
Yeah. Okay.
Then you've been using sometimes, phantoms, And we all do this, and we shouldn't really. I mean, we should use computational phantom, which you've been using a lot, or model, which is better, and keep phantom for something you can touch, like a test object. But that's a comment. So let's go to the question, because it's obviously much more interesting. I'd like to have your very, very broad feeling about the difference between reference dosimetry and patient-specific dosimetry.
Yeah,
What,
organ level,
how it's made of, and what it's made for.
Yeah, you mean in organ level or voxel level?
That's a very good question,
Organ level for
because
sure.
it doesn't really matter.
Okay.
When you're
Yeah.
doing absorb dose calculation, it doesn't really matter if you do that at the organ level or at the voxel level. You're just doing absorb dose calculation.
So the question is that what's the difference between patient-specific and if we use a model
and reference dosimetry?
Yeah.
And when do you want to implement model dosimetry? I mean, reference dosimetry, and when do you want to do patient-specific dosimetry? What are in the applications?
Yeah. Here we have a broad, it's a really broad question. We have to subcategorize to therapeutic and diagnostic, and then subcategorize the diagnosis, because in diagnostic we have a longer range of particles. So when we have, let's talk about organ dosimetry. When we talk about organ dosimetry, we have two main components. We have two main components that we have to address in internal dosimetry. We know that S-value differences, as I checked for therapeutic agents with low range, we can consider that this, with the correction of the mass, should be something not very, very bad. But the main question would be this patient-specific biokinetic. I think this one is the variability between at least two mores is too much. So we have to have some estimation from this biokinetic. But when we go through model-based, for example, if in diagnostic we have like some standard biokinetic, like ICRP 106 models that they just get the administered activity and provide the accumulated activity percentage of some source organs that are like with physiological uptake. So we're sure that for both model, this patient-specific biokinetic is important. To be honest, I can't give you a number that, for example, this reference versus
I didn't ask for that. I just really want to, I mean, and you're very, very focused, so you go deep in science. No, I just wanted to have your, general, when do we do reference dosimetry, and when do we do patient-specific? When? What are the applications? What for?
For, if I understood correctly, for therapeutic, we need kind of a specific patient-specific organ dosimetry to know the organ at risk dose, because it's over the linear no threshold stochastic effect of potential carcinogenic risk. But for diagnostic, we can use this reference model, I think.
Yeah. That's that. I mean, there's a difference between diagnostic and therapy. And therapy, we really want to concentrate radiations. We want to see deterministic effect. And reference, we have only stochastic effect. I mean, we hope. So, okay. And so that's in diagnostic that we're using reference model. Okay?
Yeah.
Yeah.
But
and yes, go ahead.
Sorry, but here the difference between diagnostic and therapeutic is that in diagnostic we had longer range particle. When we have longer range particle, at least the difference in the traveling distance that they have, the heterogeneity difference is more impacted in the dosimetry compared to the therapeutic part.
That's true and not true. That's true if you assume that long range starts after 511 kV. That's not true if you start at 380 something, which is iodine 131, where iodine 131 is being used a lot in therapy, and 2/3 of the energy is emitted by gamma. So you can have a relevance in gamma dosimetry. And honestly, no, that was not where I wanted to take you anyway. But let's carry on with reference dosimetry. That's in reference dosimetry, we have reference models, okay? And then we are trying to have reference values, reference S values, which is why now we're using a lot Monte Carlo, because there is no constraint of time. Basically, you know, if I'm generating a reference data set of values, maybe if it takes some weeks or even months, maybe it's not a big deal, right? It's not as if I had a patient in the in the waiting room and I really need to have an answer, right?
Yeah.
So for reference value, you really want to have accuracy. And when it comes to that, it's always a problem of accuracy, isn't it? I mean, it's actually very strange that for reference value, we try to be much more accurate by using Monte Carlo than for patient-specific dosimetry, where we are in therapy and where really absorbed dose calculation matters. I don't know if that might make myself very clear, but I'd like to go from what you're doing. You've been working in both therapy and diagnostics. You've been working in both reference dosimetry and you've been touching patient-specific dosimetry. However, the two applications do not have at all the same clinical impact, clinical relevance. So I would like you to speak a little about this. That was the start of, you know, difference between reference dosimetry and patient-specific dosimetry. So I wanted to lead you in difference between diagnostic and therapy. So where does it really matter to have absorbed dose calculation right?
Yeah, for sure, when we have deterministic effect, it would be more important from therapeutic. And the problem of the therapeutic is a lot of uncertainties that we have in different steps of quantification. The main problem is this patient-specific biokinetic, the imaging resolution that we have currently that show the distribution and whatever. So I do believe that in therapeutic dosimetry, even the main question is not the way that we do the dosimetry, Monte Carlo versus model-based or something like this, because they are almost, because we have like 50 or over 50% uncertainties in other part of dosimetry that is much more than the radiation transport. So if the question is that which one is more important and for which one we have to make more efforts, I would tell you that for sure for therapeutic dosimetry, we need more dosimetry. However, the question in therapeutic is not radiation transport algorithm, is not the main concern. However, in diagnostic it is.
I really agree with you. Even though, I mean, I fully accept your answer and I find it, I mean, very, very good. Except that you did again, Monte Carlo versus model-based. Does it mean that if you have model-based dosimetry, you don't have Monte Carlo?
It's kind of gold standard, just comparison with gold standard.
in my, I mean, when I read, I think there's a confusion quite often between absorbed dose calculation algorithm that can be local energy deposition, convolution with without density correction, Monte Carlo, and now you're introducing, you know, deep learning approaches, and all that allows you to compute the absorbed dose. Then on the other side, all these can be applied to organ-based dosimetry, to voxel-based dosimetry. And organ-based and voxel-based dosimetry both can be applied to reference dosimetry or patient-specific dosimetry. So you see, it's different things clicking, but anyway, yeah. So yeah, I was really wanted to hear you saying that we're putting a lot of effort in absorbed dose calculation because we can. I think we can also proudly say, and especially people like Wes and myself, who've been in the field forever, and I've seen how difficult it was to compute the absorbed dose in the good old time, which is also why we've been using a lot S values in a context of therapy, because we were not able to compute directly the absorbed dose for a patient at that moment. And now the evolution is that we can do whatever we want in absorbed dose calculation, really. And even if it's Monte Carlo, as you said, with GPU, etc. So that's focusing. And I'm very glad that you mentioned that you're going to focus on clinical application with also activity determination, segmentation, which are things that are done in Uni's lab. So that's great, because it seems to be difficult to focus on one source of uncertainty only and not touching or not addressing all the sources of uncertainties that impact the absorbed dose.
Yeah.
Anyway, no, but thank you again, because it's not always, it's very, very, I'm surprised by the huge work that you've been doing, the quantity of work that you've been doing. So
Thank you so
again,
much.
thank you for inviting me. And this is it.
Thank you.
Thank you very much. And with this, we come to Professor Rahmim. Still with us?
We can't hear you, Arman.
Looks like he's unmuted, but
Still we can't.
Mic is not working.
you go to the
Sorry, I
arrow
guess
next to the mute button, you have different options for mic input. Maybe sometimes it's
I guess he's
selected.
reconnecting.
Yeah.
Okay, can you hear me now?
Yes,
Perfect.
Yes.
loud and clear.
Yeah, it was some kind of connection situation. All right, so I have been hearing you, so don't worry about that part. So anyhow, it was a real pleasure going through your thesis, Azadeh. As others have said, you've done an impressive body of work. One of the more impressive theses that I've seen reflects on the amount of work you've been doing, your collaborative nature in a very collaborative lab, all good things. So congratulations to you.
Thank you so much.
And to Habib and also Uni. So I want to ask you, most of the great questions have been asked. I really don't have much to ask. It's hard to poke any holes in your work, but I'll just ask some few questions. You have in your Monte Carlo efforts, can you give me a sense of the computational time involved when you're doing these comparisons?
Yeah, for different, we have for both external and internal. I provided here the time for internal dosimetry. It was over than 1,000 hours per CPU, because it was for total body as well, for positron total body. And for CT, as I mentioned, we have a spiral model that, for example, if we want to really go through every 2-3 millimeter that we validated our model for Monte Carlo simulation, it was about 600 hours per CPU for one patient from total body, whole body.
Right.
Yeah.
I remember. Yeah. No, I know there's a lot of efforts to speed that up. Of course, I was approached at last year, SNMMI, by this company, which you've been hearing about, Barximetry, and they're like saying, oh, we're going to go under 1 minute with Monte Carlo. So they were saying, can we call this real time? But anyhow, the point is that people are trying to do Monte Carlo much, much faster. And so perhaps that would be a point where deep learning and Monte Carlo are going to butt heads. And I wonder if you have any thoughts about that.
Really, for real Monte Carlo, with just like GPU based and something like this, 1 minute. Yeah. I don't know. I haven't.
That's what their claim is. That's what they're claiming. But
because there are, I know that Varian has an analytical model, something that is used in the therapeutic dosimetry, that they go through like the first multiple scattering events and then stop. variant it has that even they have for internal dosimetry these days. My colleague is working on that. But even about that, I think it's about 15 minutes, something like this. However, about GPU based, to be honest, not. There is one work by Professor XU, Archer, that they claim it's in few minutes.
Right.
That it's GPU based. But yeah, right, you are right. As I mentioned, for sure for therapy, GPU based would be, because we need really indeterministic level, we need some ground truth again. But for therapeutic, sorry, diagnostic, and specifically for CT examination, you know, I mentioned specifically for CT examination because in nuclear medicine examination, we mainly have some risk benefit, that the benefit is patients are really, you know, suspicious to be sick. That's why they do their nuclear medicine examination and the dose is lower. But for computed tomography, we have plenty of computed tomography that they haven't any kind of cancer or something like this. And the dose is not yet a low dose modality. We have like at least 12 millisieverts, something like this from computed tomography. But if you say that it's in less than 1 minute, I haven't.
It's a claim. It's a claim. So it's their claim. On another note, a question I have for you, Azadeh, is I know that in our own group, Julia, before she joined our group at LMU Munich, she kind of had some data focusing on bone tumors, and she was taking a number of analytic models. I don't know if you've seen that paper, but she was normalizing them by the density weighting. She was doing density weighting for bone tumors. I wonder if you have any thoughts about the idea of doing an additional normalization there.
Yeah, actually, I read the paper that you mentioned from Julia. Yeah, I checked all of the method that they provided. To be honest, for the clinic, I know something that here, I think in the MIM software is implemented. They do something like a density correction for the central voxel.
Right.
It really correct the dose, but it's still the same assumption that we have for multiple S value, because you know we have the homogeneous, just one homogeneous volume in the area that the kernel provide the dosimetry, while when we have some voxel-wise heterogeneity, it has some impact. It's not that much impact, but we go to the accurate model this heterogeneity and provide like 10-12% at least.
That's perfectly true. Going to your that chapter where you're doing prediction of therapy dose, I have a few questions there. So it's nice to see that you're doing Q values, not just P values of false discovery. I would have loved to see in your, I mean, it's not here, but in your table 2 in the thesis, you show P values, but I would have loved to see the Q values there too. Just a side comment.
Yeah.
In your thesis.
Yeah, you're right. Sure.
So I have a few questions there. So you pick it's all about minimizing the chances of false discovery. So you pick a threshold of, I think it was 25 gray when you dichotomize the problem, you know, that 2x2 table.
Yeah.
How did you pick that number, 25?
From the literature, there is, because for those, for responders, from the dose threshold, we need kind of dose response report, right? From a paper that was, I think, published in 2019. I think I think you work with Dr. Burgard from their group, that they provided about 29 gray, but I put a bit lower to have some margins for this, about 25. And there is a recent paper from the Swedish group, Dr. Sandol, I think, that they provided the biological dose response effect about 25. So I put just 25 to say if we have this threshold in the future based on the clinical follow-up that we have from the patient, we can put some threshold and see which patient benefit more. For example, the patient that, their dose felt here in like less than 10 milligray, maybe they are not that much responders to this treatment. It's kind of just have some estimation of the dose for this patient.
Right. Yeah, it's one of those things. Okay, it's good to be literature informed because, for example, sometimes by picking the threshold, in field of radiomics too, people pick that threshold which gives you best results, and you just have to be careful about it, because if you change your threshold here from 25, say, to 29 or 30, the performances might change. So it's just a word of caution to be careful about how you do that. There's debate about how to set thresholds, but I would say literature-informed thresholds are probably a good idea. You know how some people are starting, I don't know if you know, but people are starting to throw in this SUV number of 10, and they say, okay, if a patient's SUV is more than 10, it's going to be predictive of whether they're going to have significant uptake or whether they're going to respond to therapy and things like that. I wonder if you've looked at that magical number 10 that's being thrown out there.
Not really, because the number of data that we have here is really good number with a very complete dosimetry workflow that we have here, and I could find something that Izzeddin in 2012 published that we have like about 15% of the patients that in SUV value their number is very good from a gallium PET, while the therapeutic uptake is not that good. It's the different, it comes from the differences between these diagnostic pairs that we really observed the same, that we had some patient with very good uptake in gallium, but the uptake in lutetium was lower for all of the tumors for the patient.
You had like two outliers. I was going to ask you about that too, that you kind of excluded, which kind of is problematic, right? But and I understand the problem. But that's going to be a challenge to understand these outliers. And
to be honest, Arman, these outliers are different than the cases that I mentioned. These outliers were from two different patients, and all of the tumors from gallium PET and lutetium has the same kind of good correlation. However, these two got very, very higher dose. And it was strange because we discussed also with clinician, and they were liver. One of them was the very normal liver lesion. It was like other liver lesion in the same patient, and one of them was the node lesion. That the patient was completely nodal involvement. But these two were really strange, because uptake, the ratio of the uptake from gallium to lutetium between the different lesions of the same patient was not the same for these two. Just these two was something, strange. Yeah.
It would be worth looking at this magical SUV number of 10. I worry about the statements that are being put out by others. For example, they're starting to say that if you have an SUV of less than 10, in other words, they're saying an SUV of having an SUV higher than 10 is prognostic. But I really disagree with that, because they're confusing prediction with prognostication. So usually when we talk about prediction, we're talking about what's going to, the sort of immediate results, whereas prognostication is the ultimate thing. And people forget that the ultimate goal is personalization. So if for some reason you can predict that the uptake is going to be low in a patient, that doesn't mean you give up on that patient. That actually means you should be consider injecting more into that patient. And right now with this one-size-fits-all paradigm, people are saying, oh, if patient's uptake is too low, that's it, it won't work. Whereas the whole point of doing this prediction is to be able to have better outcome for patients and perhaps inject them with higher amounts, et cetera, et cetera. So I think that understanding those nuances and perhaps talking about it is going to be very important.
Yeah, sure. The only problem that we've seen mainly in both Lutathera patient and PSMA patient here, the problem is that the variability of the absorb dose in the tumor is really higher than the variability of the uptake in the organ at risks. That's why we can imagine that if patients are in the variability of like 30% in kidney uptake, while in 100% difference in tumor, so a bit escalation makes some problems because they have the same, the same organ at risk dose. But at least I agree with you. It's really, if we can do some robust conclusion that we can make some correlation between pre-therapy and the at least course of action, that is dose, or even the response for something like lutaterol, lutetium dotatate, is we don't ask something like shrinkage immediately. We ask the prolongation of PFS and something like this. I think it really.
But you know, even if we cannot predict tumor deliveries that greatly, if we can do it for organs at risk, imagine if we can predict organs at risk very well, then you set that as the limit, and you just bring up the dose you inject to patients as much as you possibly can.
Yeah.
And then let the tumors just do whatever they want to do. But the point is that we're significantly under treating patients right now, and if you're able to predict organ at risk, then we can bring up how much we're injecting to patients, perhaps.
Yeah. This is an active area that my colleague here in University of Michigan are working, and I think the paper for kidney dosimetry has been published already in Clinical Nuclear Medicine with 18% error of prediction of kidney dose from PET-SUV and EGFR.
Right. Yeah. No, this is very exciting. I guess this is too much probably to ask, but have you thought about bone marrow at all, or it has any thoughts on that?
Yeah, I can hear them from the next room that one of the colleagues that came from Norway to our group, he's a really expert physicist in Oslo University, and he's working on the bone marrow dosimetry. We know that the problem of bone marrow dosimetry, because we have from lutaterol some uptake, however, for, even there is some problem for quantification of the time activity curve, but he's really working on that. And we read some literature that they mention in terms of bone marrow toxicity for lutaterol treatment. The pre-treatment biomarkers like platelet count, white cell count, the status of patient from pre-treatment really can predict this toxicity, and under 2 gray, something that comes from the radioiodine therapy.
Yep, excellent. Thank you. I have no more questions.
Thank you so much.
Okay, thank you very much. And with this, I would like to hand over to Professor Zaidi.
Yeah, thank you, Carson, and thank you, Azada, for the excellent presentation. I think you did very well in terms of answering the questions, maybe the tough questions by manual. I'm not going to provide feedback. I think most of the questions were asked just to gauge the PhD students. Maybe just one comment on Wes' question regarding the change in clinical diagnosis for COVID-19 patients. So the GGO is the acronym of ground glass opacity. And we're very curious, actually, to get feedback from the radiologist in the sense that anything that changes clinical diagnosis to us means clearly that this is an outlier, and we wanted to report this because we don't have to claim that deep learning is going to solve all our problems. And so I think it was interesting to report that some of the cases were really outliers. I don't have any questions. I just wanted to provide actually some feedback and say a few words about Azada, not only as a scientist, but also as a human being. So we don't have tradition here in Switzerland to make a long load issue for our PhD candidates, as the case in the Netherlands, for instance. But I'll start just from the beginning anyway. Since the time when Azada joined our group, and she's super excited, very motivated, being ready to face any challenges on her way. And she has started actually with the development of families of computation models. And here I agree, obviously, with Manuel. I prefer to use computation models rather than phantoms. Where Tianwu Chi, actually, he's attending actually the session with us now with the University of Fudan in Shanghai. He was really instrumental to get her started and to get her involved in this project. So clearly, without being motivated, hardworking, creative, and fully dedicated to your work, such results would have never been possible. However, if I ever be asked what's your main distinctive skill is, I would really emphasize your ability to move forward no matter what. When the hurdle is set too high, you never give up, and you always see it as a challenge and not as an obstacle. Yeah, so it was a pleasure to be your supervisor all these years, but I would like to emphasize also the role of your colleagues in the lab, particularly from the Symphonia European project. And with this, I would like also to thank the other members of the lab for their contribution to this project. Obviously, Uni de Raja from University of Michigan for hosting you, enabling you to continue your research in her lab. In fact, one of the papers presented today came from Michigan. I would like also to thank all members of the jury for giving from their precious time to read through the thesis, provide important feedback, and ask interesting questions. Thank you all, and thank you, Azada, for the way you are, and good luck for the future. I wish you success in your future career, being it's a career of scientist, top-level medical physics expert, entrepreneur, or any combination of these, or anything that you would like to consider for yourself. Thank you, and good luck for the future. Thank you.
Thank you so much, Habib. It's a nice word from you.
Thank you.
Thank you so much. It was my pleasure that I could be under your supervision and very good colleagues in PinLab.
Thank you, Azada. Pleasure as
Thank
well.
you.
Okay, thank you very much. So we had already a very large number of questions, but maybe there are still some from the audience. If this is the case, then please use the Zoom function and raise your hand, because otherwise I will not be able to see it. Okay. Does not seem to be the case that there are any urgent questions left. So then I would like now to ask the members of the jury to mute their Zoom and also to switch off the camera and join the Teams session that Habib had sent around. Good. So now I'm finally back. Sorry for the slight delay. So you have seen we had a short discussion. Too short actually, because we could have talked longer about all the nice achievements that you have made, and the jury was overall very, very happy and very pleased with the amount of results and the depth of the results, also with the discussion today and your presentation. And so by all means, we think that you deserve to be awarded the title of a doctor of the University of Geneva. And with this, I would like to congratulate you, Azadeh.
Thank
It
you
was
so
really
much.
a very good presentation today.
Thank you.